Well, thank you for being here. I want to say it's been a joy. Some of this talk is really inspired by the Ascaris Foundation and Dr. Chang and others. And how many of you out there, if I can see a show of hands, how many of you do some glaucoma in your practice currently? Okay, so quite a number of you. And how many of you go regularly overseas for trips? Good, so about half. When I moved with my family in August of 2015, I was currently leading the EPIC transformation at my institution and also preparing for ICD-10. So those who don't know me very well, I used to joke that I just had enough and that forced me to move to Ethiopia.
So good.
But those aren't current concerns where I work. But there are other challenges. I'm going to talk about those a little bit and how current innovations that we are excited about here could make a real difference in many parts of the world. This is my only disclosure. I'm on the scientific advisory board for CyPass, and I will be talking about that amongst other devices just briefly, though. That's not really the whole point of the talk. So when I moved to Ethiopia, I wasn't quite prepared. I mean, I knew the statistics, but about a month after I landed there, I went on an outreach. And this is a picture that was taken at 6 a.m. or 6:15 a.m. I'm walking to the site where we're going to be doing mostly manual small incision cataract surgery. And there were about 1,000 people already lined up, waiting for care. And as I would soon learn, most of them had cataracts, some had trachoma, a lot had glaucoma and other eye diseases. And it challenged me to think about how I view blindness alleviation and outreach in general. And we'll mention that a little bit. Is that mine? No. Okay. I don't think I have music on this. So glaucoma is a big deal worldwide. There's about, estimates are that 80 million will be affected by 2020. And that's an additional 20 million patients just from 2010 to 2020. So it's a big problem, and it's not going away soon. 8 million are bilaterally blind from glaucoma currently. And the highest prevalence rates are really in Africa and Asia. And it's responsible for 15% of blindness in sub-Saharan Africa. And there are a number of genetic factors. You could add primary angle closure glaucoma in Asia to that as well, but we think of POAG and juvenile open-angle glaucoma in Africa, pseudoexfoliation in pockets of the world, and Ethiopia is quite affected by that. And some estimates are in patients presenting for cataract surgery, as many as a third have pseudoexfoliation. So I see it all the time. And then pediatric glaucoma, especially primary congenital glaucoma in places like India and Saudi Arabia. Well, does one size fit all? Well, no, it's not the same across the board as we look at the world. Open-angle glaucoma represents about 2/3 of cases, and it's like I said, the highest prevalence is in sub-Saharan Africa. In Asia, in East Asia and in Southeast Asia, it's primary angle closure glaucoma is a bigger issue, and it's responsible for about half of blindness from glaucoma globally. In general, in my world, what does glaucoma look like? Well, the patients who present to me tend to be younger in age. They have higher intraocular pressures when they do come in. The vertical cup-to-disc ratios and the visual field defects are more advanced, and there's often a greater reduction in vision. Childhood glaucoma is very prevalent as well. As I mentioned, this is a patient I operated on just a couple days before I came to the meeting here. She was 5 years old and had never, she'd been treated in one eye with a combined surgery for pediatric glaucoma. There's higher rates in the developing world, we think probably because of consanguinity. Primary congenital glaucoma is the most common diagnosis, but there's a lot of glaucoma related to cataract surgery in children. So when we think about outreach, this is actually from that same outreach. As a glaucoma doctor, I see the white cataract, but my first thought is, what's behind that white cataract? And sometimes it can be difficult. One clinical pearl obviously is to check pupil reaction and check for an afferent pupillary defect. I find, though, that many of the patients I can actually see behind the cataract and get a look at the nerve and the macula. And so most of my outreaches, I look at every macula and nerve of every patient that I see. And that's not always common. I know it's not common in much of the world, but I think it's really important. And that picture on the right, that's a homemade stretcher. The patient took 2 days and was carried by family members to our outreach. And so I think it's important for those of us who are doing outreach work internationally that we think about the opportunity, not just the cataracts, but how else can we treat these patients? And that requires a lot of planning, careful planning to think about how we can manage glaucoma and other diseases. So a few weeks ago, I had 45-ish, I say 45-ish because most people where I work don't exactly know their age. Woman with 3 children under the age of 5 traveled nearly 500 kilometers to my clinic for a second opinion. The good news is that her vision is 20/30 in both eyes. Now her pressure is elevated. She had just been started about a month earlier on 2 medications. And her pressure was 31 in the right eye and 22 millimeters of mercury in the left eye. Now the bad news, and I have to preface by saying when she walked into my clinic, she didn't say a word, she looked at the ground. She was despondent because the doctor that she had seen in her rural area had told her that there was no hope. And this is her 10-degree visual fields. So what do you do with that? So in this case, I didn't do MIGS because I didn't have MIGS on me, and it probably wasn't the right thing at the time. I did have a tube shunt and an SLT, and this is 1 week after the tube shunt. Her vision was still 20/30, and she is going to come back to visit with the help of, she has adult children as well. But follow-up is a big issue, and I'll mention that a little bit later. So what we decide to do sometimes determines what kind of surgery and how we treat patients. So what are the challenges? Well, one of the challenges is access. In many countries like Ethiopia where I work, roughly 80% of the population lives in rural areas. And so for patients getting to where they need the care is difficult. The cost of care is a challenge. This is actually a woman living on the outskirts of Addis Ababa, a city of 6 million, but she had never been to a doctor before because it doesn't cross her mind that she could afford and go to a doctor. So we actually do home visits in some cases, and we started doing that. And then a big issue is the availability of eye health professionals, and especially ophthalmologists. So what is the ratio? Well, the ratio of ophthalmologists per population in India is about 1 in 100,000. In Asia, it's about 1 in 200,000. And in much of Africa, it's up to 1 in a million. And so how do we address that? Another challenge is awareness of disease. And over 90%, in some cases almost 100% of patients who have glaucoma in the developing world don't know that they have it. There's also can be sort of a misunderstanding of diagnosis. So many of my patients believe that glaucoma is reversible or the damage is reversible, and they think that their vision loss is from another reason, not the glaucoma. And then related to that, they have almost across the board, they have an expectation that whatever treatment I provide will help them see better. And we know from many, many studies that poor understanding of disease leads to poor adherence, refusal of surgery, depression, and lower quality of life. So education and community health development needs to be a really important part of what we do. Another challenge is adherence. And this is one of the fellows that I was recently working with, Dr. Konjit at St. Paul's Hospital, a government hospital. Cost of medications. So in India, for example, the range of cost of medications for a patient's salary is about 13% to 125% of their salary for one medication. Where I work, latanoprost, the generic, is cost about $20 US. That doesn't sound like a lot from America, but if you think about the fact that half the population in Ethiopia lives on less than 60 cents US a day, that's a lot of money. So when I have a patient who needs more than Timolol, I start panicking a little bit and thinking about what the next step is. And that's very different than my practice in Chapel Hill was, where I could have a patient on 3 or 4 medications and SLT and all kinds of options. We don't have all those options. The availability of medications. There have been times where the only thing available, even in the city, is timolol and pilocarpine. And then belief systems play a big role. So some of my surgical patients I've had disappear for a month at a time, where they go visit a traditional healer or counsel from their extended family. A lot of people are affected by a sense of fatalism, meaning that this is just the way it was meant to be. This is their lot in life. And so to overcome that and try to convince them that their future could be different. And then a general mistrust of healthcare. And we have that in America. My own grandparents, my grandfather passed away because he refused to see a doctor, had never gone to a doctor in his life. Things are changing here, but there's generally a mistrust of healthcare, and that can be for a lot of reasons. It can be the way they're treated by the system and by doctors. It can also be bad outcomes or what their perception is. And so we have to find ways to overcome that by providing compassionate care and involving them in the process. And then finally, one of the biggest challenges is social consequences. So blindness not only affects the person that you're treating, but it affects the whole family. And much of the world, including where I work, children are often affected. This is actually from an outreach with Vision Care Services that we did in eastern Ethiopia. And this young girl, her elders and her family aren't convinced about their cataract and glaucoma treatment options, but the girl is excited because she may have a new lease on life. If we can get her elders seeing, she can actually go back to school and have a future. And right now, her full-time job is taking care of the elders and her family. So in 2013, I co-wrote an article on Glaucoma Today with my chair, Dr. Donald Budins, who you may have know from UNC or Bascom Palmer. And I actually wrote pretty brazenly that the only real answer to treating surgical patients in Africa is a trabeculectomy with mitomycin C. But I added that there is need for further research and treatments for lowering pressure in Africa and elsewhere. At the time, I was doing trabectome and had dabbled in eye stent a little bit, but MIGS procedures, microincisional glaucoma surgery, was not a big part of my practice. But there have been a lot of recent developments, and I won't go into the details, but bypassing the trabecular system, there's a number of devices on the market now, iStent and iStent Inject if you're from Europe or Canada, other parts of the world. Ab interno canaloplasty or trabeculotomy, a GAT, is another option. Trabectome has been around for quite a while, and the Cahook dual blade from New World Medical. And those are all ways of bypassing the trabecular meshwork or augmenting the trabecular outflow system. And then there's the supraciliary or suprachoroidal option with CyPass. And then the Zen gel stent, which is a new device, which works like a trabeculectomy, but like all these devices, is an ab interno approach that involves a lot less surgery, a lot less time. And so Ascaris Foundation sponsored a training in CyPass about a month after I arrived, and I've continued to do training. This is in Jimma Hospital in southern Ethiopia. For those of you who are new to MIGS or thinking about it, part of the challenge is just the positioning of the surgery. So you have to angle the microscope and angle the patient's head away from you, and that can be challenging. The first couple times I did it, I found my seat was too high, and my arms, I was like a robot trying to operate. That was different. And then using a gonioprism in surgery, and that's a really important skill. That's part of training. But you can see here one of my colleagues, Ethiopian colleagues, same day is doing angle surgery. And so it's a teachable concept. So if you can identify sort of measurable concepts that can be taught, that can make a huge difference. So is it a potential game changer? Well, what are the pros? It's kind of wrapping up here. We do know, we have good data that there's, in most patients, the majority, there's a measurable IOP lowering, often 20 to 30% or more. There's a greatly enhanced safety profile, and that's the big attraction. We preserve the conjunctiva in most cases, in most of those examples I showed you. Decreased medications, quicker recovery of visual acuity, and efficient. And this is actually really important, as Dr. Cheng was talking about. If you want to do 50 or 100 cases or more a day, it's difficult to do that with a tube shunt. But if you have a device where you could control pressure and it added literally a few minutes to your case, that would be advantageous. And it can be easily combined with cataract surgery. I would include with a well-done MSIC surgery as well. It is possible. The cons, cost for sure. Some are more costly than others. The need to develop a market if we're going to really scale up on the order that's needed. And then long-term data and research and more training. But I would say that the training is a plus also, because if you think about, some of you are probably comprehensive ophthalmologists who have integrated glaucoma care, because the surgical adaptation and the postoperative care of MIGS is a lot more attractive than some of the other things that we do in glaucoma. So with that, I'll thank you, and there's my family waiting for me to fly out tonight back to Addis Ababa.